there is a proverb where I am from that is chinoziva ivu kuti mwana wembeva anorwara. And then what that means is what knows is the soil that the child of the mouth is ill. And I think it is very apt because who knows what people need best than the people themselves. So in this podcast, in this episode, we're going to focus on the power of the community and the community voices. So I have here as my guests 3 very distinguished advocates for TB and HIV within the African continent. I have Edna Tembo from the Coalition of Women Living with HIV in Malawi. HIV and AIDS in Malawi. I have Stephen Anguva Chikoli from PAMOJA in Kenya. And I have Melody Mukundwi from Jointed Hands Welfare Organization in Zimbabwe. Thank you very much for joining us. And this is On the Red Couch. Yeah. So Edna, can you tell us a little bit about yourself and what it is you do, and just explain the attitudes of people within your community towards TB and HIV and prevention in general?
Yeah, thank you very much. I'm Edna Tembo, working for Coalition of Women Living with HIV AIDS in Malawi. Our focus is on HIV prevention, treatment and care. The same with TB, we are also looking at prevention, treatment and care. And as an IMPAACT4TB partner, we are focused more on TPT advocacy, whereby we advocated for TPT to be included in the guidelines of Malawi. So for the people at first, they couldn't believe in TPT because of the issues which were arising in INH, the side effects. So when we came to talk about TPT, they were like reluctant to get it. But with 3HP, now we have changed the mindset. People are happy with 3HP. It's short, tolerable, and very effective. So people are really happy with 3HP as a TPT choice of drug. Thank you.
Thank you. Thank you very much, Edna. Stephen, is it the same in Kenya?
Thank you very much, Maka. My name is Stephen Anguva Chikoli. I'm the Executive Director, PAMOJA TB Group, which is a community-based organization in Nairobi, in Kenya. As the word comes, is PAMOJA TB Group. So we are people that have survived TB, that are using our TB experience to empower others. So for us, TPT experience has been a little bit different. We used to know that this TB preventive therapy is for people living with HIV, because over the years, the country was using isoniazid preventive therapy, which was given for 6 months and mainly for people living with HIV. So when the conversation came in that even people that have not living with HIV but their contacts of people with TB should be given a preventive therapy, people are wondering, do we now take TPT when we are not sick all these 6 months? So some of them were taking the drugs, but they were not swallowing them. So they were storing the drugs in their rooms. And we found out that most of them had TPT, like in the register, documented that they have taken TPT, but they were developing TB. Then we asked, what is the problem? Then they said swallowing many drugs, side effects, and this treatment going for 6 months is not good. So when the IMPAACT4TB project came, it was like a lifesaver because it came in with new innovation, which is 3HP. And now we started talking to people about 3HP, short course. You just take 1 dose per week, and it's only 12 doses. Mm-hmm. And now the people have adapted it, and the demand is so high. In fact, facilities are now overwhelmed, and they are now even getting a component of stock out. But the demand is so high because people are now accepting, and they want to use TPT. Even now, if you talk to somebody, they tell you, where is it? I want to start TPT. Yeah.
All right, thank you very much. That's very interesting that now we have demand where people are beating down the door, whereas before you could never catch them to give it to them. Melody, can you give us the perspectives from your communities?
Thank you. Thank you very much, Maka. My name is Melody Mukundwi. I'm from Joint Alliance Warfare Organization, and we're also the host of the Stop TB Partnership Zimbabwe. So I think our experience in Zimbabwe, we borrow some from Malawi and some from Kenya as well. Like just as Steven has highlighted that initially, TPT was mostly prioritized for people living with HIV. So I think also from Zimbabwe, the experience is the same. It was mostly focusing on HIV, people living with HIV. So you find that even when we started our work as Jointed Hands, we were also focusing on HIV. But now looking at the situation at how it was before the IMPAACT4TB project, we note that because during that era, there was IPT. And people taking IPT, the time was for long. There were a lot of side effects. There were a lot of myths as well, because we can't say everything that the community believed was true. Because when there is lack of information, people also spread what they believe to be information. So there were a lot of misinformation, a lot of myths, and some of them then being the side effects, of course. So that surrounded IPT, which was the TB preventive method that was available. So because of that, some would just collect the medication because the clinicians have given them, but they were not taking the medication. So which means whatever was the health system was trying to do was not happening. So when we then became a partner for the IMPAACT4TB project, our focus was now to say, how then can we work with the community to make sure that in as much as there is now a new option that they can take, which is 3HP, if they are not aware, if they can spread other information, or if they can teach each other as community wrong information, I think the result was going to be the same as IPT, because already people were engulfed in fear.
Yes.
So we then said, okay, what we need now to do is to make sure that we conduct treatment literacy for the community so that they understand TPT. And through that process, we would also be doing a treatment preparedness. Because the moment you get to the clinic and you're not prepared to take this treatment, it becomes a challenge as well. But if you know about the treatment and you are prepared to take it, it's very easy for you to say, please, I haven't taken my TPT, give me. Now, this is now community-driven demand.
Yes.
It's now the community that is saying, I want this service because it is good for me. So to do that, we developed this toolkit.
Okay.
Yes. We collaborated with the Ministry of Health, and we wanted all the information that is available around TPT, although we were mostly biased around 3HP, but we covered every option that was available, making sure that the information that is engulfed in that toolkit is reduced. It's very easy to understand. It's something that is for the consumption of the community. So we simplified the information and made it very easy to understand. Then when we then developed this toolkit, we also made sure that we worked in collaboration or in close consultation with the community. I'm sure even if you look at the cover of this, you see these are real people. They're not fake people. These are people living with HIV.
It's not a stock photo.
It's not a stock photo, yes. These are, it's not AI. These are people, and if you flip around, you also see throughout the toolkit, there are real photos of people who even up to now are still proud to be part of those toolkit. They're very proud of themselves because they are part of the toolkit. So we then developed in consultation and in collaboration, even with the communities. So after developing this, we then trained the community members. We started with expert patients. We also trained community health workers so that they are able to then use this. And this were then printed. If you see this, it's in Isindebele.
Yes, I was going to say.
Yes, it was translated from English. Then we had Shona and Isindebele. So we also made sure that it's in vernacular so that those who don't really understand English can still communicate with communities in their own mother language and understand the treatment of choice that they have to take. So it has been a very good experience, and we have seen great improvement, great results from this, and up to now we continue to use it. The copy that you're holding was even printed with support from another project, because this became a national document. If you see this, it's even written that it was supported by the US funded project. So even other projects came in and we roped them in so that they train their cadres, they print, they provide resources to continue the impact that was then left by the IMPAACT4TB project.
So what you say is very important because you already started thinking about sustainability. Because the project had a start and end date,
Yes.
but it needed to continue going.
Very
So there's one thing that has resonated was the partnerships that we discussed. So part of it was the scientific partners that were bringing the scientific evidence. And then there was the market shaping team that brought down the price. But we know that even if you have the product at the right price, if a lot of what you do is not done, then it doesn't get to the community. So can you speak to some of your own partnerships in country that help this? So in addition to educating the community, what are some of the partnerships in country that you had that enabled your work? So we can start with you and go back.
Thank you very much. I think this has been a child of everyone because what we did also as Jointed Hands, after we had finished developing this, we also trained networks of people living with HIV. Remember, initially our focus was still on people living with HIV. So we took all the networks of people living with HIV. In Zimbabwe, we have got the Zimbabwe National Network of People Living with HIV. We've got the Papwick Zim, which is a network of women living with HIV. We've got young people also, the network of people living with HIV. So we took those different groups and we made sure that we trained them on this so that they can also take the information to their different communities and their networks, so that at the end of the day, we are working together to cover the whole country, because the project was only focusing in just a small part of the country. But then through that, we made sure that we spread our wings to cover the entire country. So apart from that, starting from the onset, start working with the Ministry of Health was also a very powerful collaboration, because if we had done it on our own as a partner to say, oh, we have the resources from IMPAACT4TB, we can do it, it was not going to go anywhere. So this toolkit is a government document.
Yes, okay.
So we collaborated with the Ministry of Health and they have ownership of the document. And everything that is written here, they're in agreement with it. So this is authentic information. So also, apart from us reaching out to partners to say, you can print this and make it available in the areas that you work, the Minister of Health is doing the same. They are also reaching out to partners to make sure that this is also utilized. This also even makes sure that we don't do duplication. Because without making sure that the mother body is aware, every partner will be saying, I'm developing this, and we are duplicating efforts, wasting resources, when we can then tap in one thing and then make sure that we use the resources to make it have more impact. So these are some of the partnerships that we've had at the moment. I'll give others the chance to speak.
Okay. Thank you. In Kenya?
Yeah, thank you very much, Maka. I think in Kenya, PAMOJA.
Sorry, Stephen, when you start, what is partnership in Swahili? Do you speak Swahili?
Yeah, I speak Swahili.
Okay, what is partnership in Swahili?
Partnership is just like PAMOJA, coming together.
Oh,
yes.
so
PAMOJA means coming together.
Okay,
We call it PAMOJA.
Okay, so what was PAMOJA like?
For us as PAMOJA, in terms of partnership, we came in as the last born baby, because there was another partner that was implementing the IMPAACT4TB project, that is Stop TB Partnership Kenya. So we came in like 2 years after them, and we continued the work that they have done. They had already done. But for us, we first said that we want to go and change in terms of policy, because for them, the idea was to bring in the political goodwill. But for us, we brought in the component of, even if we have good political will and we don't have policies, and policies have not adapted the component of short course TB preventive therapy, then we can have the money, but we cannot even use it. We cannot even have the commodities. So we brought in the component of engaging the TB program and ensuring that they understand this idea and this project, and then they can adapt these short course and put them in the policy. And that is how the country launched the LTBI policy, which now guides the implementation of latent TB and the treatment of TB preventive therapy. And the stronger partnership that we brought in was engaging the communities at grassroots level. That was the greatest partnership because, as I said earlier, the communities knew that TPT is only for PLHIV, but now was bringing in the component of, you see, even you are at risk of TB, there is something that can help you not to get TB. So that was also a very strong partnership that came on board. And through this journey, the TB program, after putting it as part of the policy, they have now put in allocation to ensure that there is continuum of the work that IMPAACT4TB has done. Because before IMPAACT4TB, nobody was talking about communities and TPT. They were only focusing on healthcare workers, and they were getting it wrong. Because also healthcare workers, they were just ticking a box. Oh, Maka, you've come, you've collected your meds, see you next week. But there was no that component of follow-up and support adherence. So the medicine were going, they were ticking, they have received 10 commodities, they have given 10 commodities, so them their records were clean. But what about the effect? So we came in and brought in the aspect of why we need to do counseling before we initiate TPT, and why we need to follow up people so that it's not just dispensing medicine, but it's about people consuming the medicine and us seeing the impact by reducing the component of infection of TB in the community. Yeah.
All right. Thank you very much. Thank you. Edna, what is partnership in Nyanja?
Umodzi.
Modzi.
Umodzi, or we can say PAMOJA. Yeah, so JHWO and Swahili, they are cousins, you know. Yeah. So for Malawi, the first implementer for IMPAACT4TB was KNCV, who brought us together as civil society and also engaged us more in advocacy. I think you remember the issue of nitrosamine, which I was there in Malawi. It was KNCV who brought us together to say, let's fight for this and ensure that our people in the communities have the knowledge and they are motivated to come back to treatment. They shouldn't be taken off because of the issue which has arisen. So coming together, PAMOJA, we engaged also PEPFAR because we knew that PEPFAR was the one who was supporting the procurement of TPT. So PEPFAR was brought in, and in Malawi we organized ourselves as Civil Society Advocacy Forum. So this Advocacy Forum is a stronghold for civil society, which also looks into HIV and all other related health issues. So when it came to COP processes, we are the team that was looking at which areas do we need to advocate for. So we had this document, Liulatu, Our Voice, which we produced at every COP. So you would follow that these are the issues that the civil society are asking. And we had an area whereby PEPFAR has to respond to what they have done. The government also has to respond what they have done on TPT and the other stakeholders. So you would follow that we have done this, ask, and here we are, and this is where we are going. So, so we were working in partnership with PEPFAR, and they have really recognized us at community level. And in Global Fund also, we are the same grouping engages in Global Fund. And we also engage in technical working groups where we give updates. And as COWLHA, we have also been recognized. We are in that NTP technical working group and steering committee whereby we talk about TB in general, like prevention, treatment, and care. So TPT is also one of the things. And during those processes, we made sure that TPT was included in the treatment guidelines because our guidelines had INH for life. And then it and then it was reduced to say, no, for life it was too much. 9 months.
9 months.
Yeah, so you find the INH, when people come to collect ART, they will collect with INH, and you find it behind the walls. People dump it there, and in T estates, you find in the T estates, they have dumped it, they go with the ARV, the INH, no. So We have done that, and we also have the TB CSO network, which is specifically looking at TB, while the Civil Society Advocacy Forum looks at general health. Yeah, so the TB CSO forum also looks at specific issues on TB, and we have been doing a lot, meeting the parliamentarians. We had the TB caucus. Unfortunately, most of those parliamentarians lost their seats, so we had to start again afresh to mobilize the parliamentarians to support us in the allocation. And also currently, we are also doing the advocacy on health financing. And TB and HIV, it's our focus to say domestic resources should focus on TB. So at community level, we have trained most of the members in the coalition. We have 64,000 support group members.
Okay.
The whole Malawi.
Okay.
Yeah, so we usually go into these support groups, train them about TPT, and also ensure that they are also training people outside the support groups, because we cannot have everybody in the support group. It's by choice. So those who made choice are 64,000, and we train them, build their capacity, and we have formulated committees at the district level. So we have a district coordinator and the committee, which comprises of members who come from various traditional authorities, so that they also disseminate message in their communities. And we have created a WhatsApp group whereby we also update them on the issues that are upcoming on TPT or other issues related to HIV. And even when I was coming here, I got those questions that what has IMPACT4TB done to the community? They responded, and they even gave me their asks to say, ask them not to stop, but to continue supporting us. Because we have been implementing the IMPACT4TB in 2 districts, but not covering the whole district. There are some areas which were left. And we have not only stopped there, we also asked UNAIDS, who supported us also, to go into other areas, to do capacity building to the communities. So we are really doing something. And for us, we say IMPACT4TB project has not ended. It's beginning. So we have that trust that we'll have it. And even if we don't have funding, but our members are keen to go on and disseminate and build capacity in the communities.
Okay.
Thank
So I have one last question for each one of you. So if you can give me the first things that come to your mind. So, Edna, you mentioned something very critical, which is the financing issue right now. And I have a question. So because you're sitting on a red couch, you cannot not feel heat. So what is a sustainable way of funding communities? Is it perhaps the model that has been prevalent so far, which is moving from one grant to the next? Or is there a way that we can sit down and rethink the community funding model to something more sustainable? Is it a social enterprise? So moving from, is it an NGO, I don't know what the status would differ in countries, to a social enterprise where there is some income generating work that is tied into your advocacy and demand generation. So what are your thoughts? And just the last thoughts around that. Because we understand, domestic resourcing, but is there an element of domestic resourcing?
I think for me, the best way is to support the communities directly, but also ensuring that there is something that can be revolving that funding, so that when the support or the donor withdraws, they still remain with something to do, and they keep on going. Yeah, because the donor dependency is the one which is most killing us all. Yeah, so I would think if we have that, like what you have mentioned, social enterprise, whereby we have the resources, we do something that if the donor goes, we still have that life to go on because we are able to do something with the resources.
Okay.
Yeah, thank you.
All right.
Yeah, thank you, Maka. I think that is a very pertinent question because even the governments are struggling with the component of sustainability. So I think every time there is a call for proposal, they usually ask you to write one pager of sustainability plan. And communities usually have good ideas that you write there. But the end of project, that page is not referred to, is not referenced to. So I believe that the component of building up a strong structure whereby any donor that wants to bring in resources, the community does not have to know that it is donor X, donor W, but there is something that, like it's a vehicle that is there.
Okay.
Whether you fuel at Total, at Shell, the fuel is there. So you don't know who is the fueling the vehicle. So I think that is a component of sustainability that I feel. I know now currently countries are talking about social contracting.
Yes.
But with which money?
Yes.
Africa, we've been very poor in terms of sustaining our health financing. We have not adhered to the Abuja declaration of 15% of our health budget. So even when you talk about social contracting with government, it's still a gray area that we need to go. But in terms of donors coming together and pulling the resources together, the likes of what Global Fund did, because in Global Fund, the money is not written French, Africa, Europe, but it is Global Fund. It is not owned by anybody. It is a fund that is revolving, that is there. And it has made strong strides, but also empowering communities at the grassroots to know that this basket is here and you can do something to ensure that it is refilled, not waiting for somebody from out there. Thank you.
Revolving fund, he says. Okay.
Thank you very much. This is a very important and thought-provoking question. So, whenever the conversation of sustainability is started, I think community continues to be pushed in a corner. Because even if we are to talk about the pager that Stephen is referring to, you visit most of the proposals that are written at any level, sustainability always revolves around community. The community will continue to do this, the community will do that. So you see the burden of sustainability is always being pushed to the community. But what are we investing in this community to make sure that when we want that sustainability, it is there?
Yes.
Because when you look at the proposal, in most cases, community sometimes gets less than 10% of the total grant, for example. And also, even if community applies for a project on their own, in most cases, community, even for their administration and everything, it's earmarked. Don't exceed 10%. So my question now, unfortunately, this I'm sure I'm not going to be able to answer this. But what I have are questions. So my question now is, if you then give communities 10% throughout the grant, and then you say after the grant, please sustain. Sustain from where? Because even when they are funded, they are still using their own sweat and blood. So when you take away those little resources that you want, how do you want them to keep going?
Okay.
Where is the oil?
Reserves.
So what I think is we want sustainability to work, because sustainability will never work in one day. It will never work in 1 year. So the time to start building, I believe, is now. So for that to happen, let's invest. True investment. Let's make sure that that cap is removed from 10%, because 10% is already not enough even for communities to get salaries. Because we cannot expect someone to work the whole month and get $15 to say, oh, that's your allowance because you're a volunteer. But you still expect that same volunteer to continue for 20 years. That will come after the project life cycle. So in as much as communities are there and are willing, let's not take advantage of them.
Absolutely.
Thank you.
So IMPACT4TB built a cohort of community partners that were trained in the science in order to facilitate demand generation. So thank you for joining us on this episode. This has been On the Red Couch, and I am your host, Makaita Gombe.